So today for chapter 8, notice this term that's right here, articulations. Now I know I've mentioned that a couple times. Remember, articulation is a joint. So anytime you see that term articulation or in our, it just means a joint. It's where two bones come together. So this chapter is all about joints, and we're going to walk through essentially how we can classify our joints. We can classify them functionally, which is essentially their function. How much movement does the joint have? So I'll write that down. Or we can classify them structurally. And structurally is essentially what is holding them together. Okay. So those are the two ways we can classify our joints, and we'll walk through those. And then we are going to walk through, in terms of the structural classification, we're going to walk through 3 of them. So we have joints that are called fibrous joints. They are held together with fibrous tissue. We have joints called cartilaginous joints, where there's cartilage between them. And then we also have a type of joint called a synovial joint. A synovial joint has a cavity. And these are actually the most common joints in the body. If you can pop a joint, you know, like if you can crack it, like you crack your knuckles, you crack your neck, it's a synovial joint. And because they're the most common joints, we're going to walk through a lot about synovial joints. So we'll talk a lot about what do they look like, what makes them more stable, what types of movement can you have in a synovial joint. And then we'll go over some very selected synovial joints. Now on here, I have that we're walking through the knee. We'll also walk through a few other ones as well. Then at the end of the chapter, we'll go through some joint injuries. We'll talk about things like arthritis, which are super common. Now, I will tell you that in about the first 15 minutes of going through the chapter 8 lecture, we're going to hit about 20 new terms. So there are a ton of terms in this chapter. A lot of the terms sound the same, but they mean something very different. So the best way I think to study chapter 8 is to make an outline. And so I just think it's the best way so you can see how everything fits together. It just makes it a little bit easier. All right, so we already know this term articulation. It is a joint, so it's where two bones come together. Now, it is really important that we have joints in the body. They allow for movement. But remember, if you have two bones that are coming together and they're held together with soft tissue, that is obviously going to be the weakest part of your skeleton by far. So I'll walk you through in this chapter ways that we can make our joints stronger. So things we can do to actually reinforce a joint. Now, obviously, the function of your joints is to give you movement, and it's also, they're holding your skeleton together. We have, 206 bones in the body, over 206 bones in the body, and they're held together at joints. All right, so I told you that we classify our joints 2 ways. Functionally, based on how they move, and structurally, based on what's holding them together. So we're going to hit the functional classification first. Okay, so again, functional classification is the amount of movement that's allowed by the joint. Okay, that's what that means. And there's 3 functional classifications. Okay, so there is a Synarthroses. And a Synarthroses is a joint that is completely immovable. So it's where two bones come together, but you get no movement. A great example of this, one that we talked about last week, are the sutures that are in your skull. So remember where like your parietal bones come together, your frontal bone, your occipital bone, all those sutures, those are clearly joints. It's where two bones are coming together, but there's no movement, right? You're not hinging or moving those cranial bones. So that's a synarthrotic joint. We also have what are called amphiarthrotic joints. And so these are joints that are slightly movable. So a good example of this one would be like the pubic symphysis, right? Where your two pubic bones come together and you have that pad of cartilage in there. You get a little bit of movement when you're walking, but it's not a huge range of motion. So it's slightly movable. And the way that I remember amphiarthroses is I think amphi, and I think this is really weird, but I think amphibian. And an amphibian can live on land and in the water, so it can kind of do both. So I always think of an amphiarthrosis as sort of in between something that's immovable and freely movable, right? It can kind of do both, so it's in between. And then the last one is a diarthroses. Diarthroses are freely movable joints. These are going to be most of the joints in your body. Essentially all of your limb joints. So all the joints in your arms and your legs, they're all going to be considered diarthroses, right? All of these are freely movable joints. Okay, so those are our three functional classifications of our joints. Now we're going to walk through the structural classifications. And remember, this is the things that are binding your bones together. What structure is holding those two bones together at that joint? So I told you we have three of those. We have fibrous joints. These are just held together with fibrous tissue. Cartilaginous joints, which have cartilage between those two articulating bones. And synovial joints. These are the ones that have a cavity between the two bones. Okay, so we're going to walk through our fibrous, our cartilaginous, and our synovial joints. We're going to talk about those, and I'll show you some examples of each of those. So fibrous joints, again, they're held together by fibrous tissue. There is no joint cavity. Remember, the only kind of joint with a joint cavity is a synovial joint. And most are immovable. So if we think back to our functional classification, immovable is a synarthroses. Now, remember, let's go back because I didn't actually mention this. This ending here, arthroses, just means joint, right? Think arthritis. Itis is inflammation of. So arthroses is just a joint, right? So if you see that term, you know what we're talking about. So most of our fibrous joints are synarthrotic. They're immovable joints, and there's three types of fibrous joints. Okay, there are sutures. These are the ones in the skull. Okay, those are obviously not movable. They're synarthrotic. Those bones are all held together with some fibrous tissue. There's Syndesmoses and Gomphoses. Okay, so I know you don't know what those are, so I'm going to show you pictures of those. So the only one you're probably familiar with is that suture. Okay, so here's a suture. Again, if we look at this picture here, you can see we're looking at our skull bones and where they come together. So remember, we're still talking about fibrous joints, so bones held together with fibrous tissue. And when we're looking at a suture, the bones are held together with really short pieces of fibrous tissue, okay? And the bones are held together really tightly, but it does allow for them to grow during youth. So it allows the bones to expand and get bigger. Eventually what's going to happen is as you get older and your bones stop growing and the growth plates fuse, those sutures become symphyses. You don't have to remember that, so I'll cross through it. I'm not going to ask you anything about those. You just remember sutures are in the skull. Okay, y'all have enough to remember. Okay, the second kind of fibrous joint is a syndesmoses. Now I mentioned you might not be familiar with this one. A syndesmoses is very similar to a suture, still has fibrous tissue, but the fibrous tissue is longer. And so you can see in this example right here, we're looking at the tibia and fibula down by the ankle. And now you can see this fibrous tissue and you can see that it's a lot longer. That's a syndesmoses. It is going to hold bones together that essentially run parallel with each other. So tibia and fibula, the other example, radius and ulna, okay? Those are going to be held together by syndesmoses. The amount of movement, it's not a lot. They're really amphiarthrotic. A lot of times they're either immovable or just a little bit movable, And then the last type of fibrous joint is something called a Gomphoses. A Gomphoses is a peg in socket joint. The only example that we have of this is teeth, the teeth sitting in the alveolar socket. So you can see in this image here on the right, you can see the fibrous tissue right here, and you can see how short that fibrous tissue is. Again, it's just holding the tooth to the bone, okay, into that alveolar socket. Now, we actually call that fibrous tissue in there, we actually call that the periodontal ligament. And you may have heard of that before. We're going to talk way more about teeth in AP2. But the periodontal ligament is holding the teeth in place, okay? Now we can also classify our joints, all the ones we just did, those three, sutures, syndesmoses, and gomphoses. Those are fibrous joints. We also have cartilaginous joints, where they have cartilage between the articulating bones. Again, these don't have a cavity. Only ones with cavities are synovial joints. And there are two types of cartilaginous joints, Synchondroses and Symphyses. Now, a Synchondroses, if you look at that name, right, it has chondro in the name. So you should know, if you see that, you should know immediately, oh, that's a cartilaginous joint. So if I ask you a question on your exam that says, which of the following is a cartilaginous joint? And you see Synchondroses as one of the answers, that should be easy peasy. You should know it's cartilaginous. All right, so a synchondroses is where you have some cartilage uniting the ends of those bones together. All synchondroses are synarthrotic. Remember, that means that they are not movable. And examples of these, epiphyseal plate, right? Remember this big bar of cartilage in here. It's uniting the epiphyses and the diaphyses together. That is considered a synchondroses. It is an immovable cartilaginous joint. Another one is right here. It is the costal cartilage that connects the very first rib to the manubrium, to the sternum. The reason why this one is considered a synchondroses is because this is the only joint, the only costal joint that does not move. All of the rest of your joints that connect the ribs to the sternum, they allow the ribs to move up and down. This helps with breathing. It increases your thoracic cavity space. But this very first connection here, there's no movement. There can't be any movement because you have a collarbone, you have a clavicle right on top of that. So it can't move up and down. Okay, so that one is considered a synchondroses. Now we also have a symphyses. Symphyses, you already know one of these, right? The pubic symphysis, right? This one has that term in the bone marking. And so this is basically hyaline cartilage that essentially covers the ends of those bones, and then there's a pad of fibrocartilage between. So this is definitely a cartilaginous joint. There's just a lot of cartilage in there. And a lot of times we'll find symphyses anywhere where we have a lot of pressure and we need to absorb shock. So the pubic symphysis, another good example is here between the vertebrae. Now in the last chapter, remember we talked about the intervertebral discs and how you have this pad of cartilage sitting on the body of your vertebrae. It helps to bear some of that weight, acts like a shock absorber. So we say that your symphyses are amphiarthrotic. There's a little bit of movement that happens there. They are designed mostly for strength, a little bit of flexibility. Okay, and those are some examples. So we've done our fibrous joints, we've done cartilaginous joints. Okay, and then the last kind that we're going to do, and honestly, this is what the whole rest of the lecture is going to focus on, are synovial joints. These are the most common. These have a cavity, so there's a space between those two bones that are articulating, and that space is filled with fluid. So now y'all can see what I meant when I said that in the first 15 minutes, we're going to hit tons and tons of terms. So that's why, honestly, the best way to study this chapter is to make an outline for yourself, okay? All right, so a synovial joint. Synovial joints are freely movable joints. So remember that term is diarthroses. That's a freely movable joint. And examples are all the joints in your limbs and honestly most of the joints in your body. So let's look at a synovial joint. What does it look like, right? If we look at a synovial joint, obviously we have the two articulating bones. Okay, so these are just generic bones they're trying to show you. And now you can see where they come together, there is a space. Okay. You can also see around the ends of those bones, you see it in blue, I'm just kind of coloring on top of it. That's called articular cartilage. Remember, an articulation is a joint. So you always have articular cartilage wrapped around the ends of those bones where they form a joint. We also have a cavity, so we have a space, right? We can see the space in here. That's called our synovial cavity. The space is filled with fluid. There's always going to be a fluid in there called synovial fluid. We'll talk more about that in just a minute. Then we also have our articular capsule. The articular capsule is this right here. Circle it on the sides. The articular capsule is kind of holding the fluid in that cavity. And then lastly are reinforcing ligaments. And you can see one of those right here around the side. Depending on the joint, you may have a lot of reinforcing ligaments, like the knee joint, for example, has tons of reinforcing ligaments. And the job of these ligaments is exactly what it sounds like. They are there to reinforce. Remember, joints are the weakest part of your skeleton, so they need reinforcement. Okay. So I want to go over each of those structures with you that we find in a synovial joint and just talk more about them. So the first one, the articular cartilage. Again, this is the cartilage that covers the ends of those bones. It is hyaline cartilage. And it is great at providing a little cushion on the bones. It absorbs compression and shock. And really its job is, if you've got two bones that are articulating, the last thing you want is every time you move the bones and move that joint, you don't want them rubbing on each other. So it really helps to reduce friction. Okay. Now we also have a joint cavity. We call that the synovial cavity. That's the space. And again, it's filled with synovial fluid. So synovial fluid is kind of cool. It's actually made from your blood. It's made from blood filtrate. And it is a very viscous liquid. So that term viscous means that it is really thick. So what happens is your body will create the synovial fluid from your blood, and it will weep into the synovial cavity. And it's really thick. But what happens as you warm up your joints, like as you start moving your joints more and more and more, it gets warmer in there and the fluid actually gets less viscous. It actually thins out. The way that I always think about this is sometimes I'll cook with like sesame oil, and a lot of times I'll put sesame oil in the refrigerator. And if you put oil in the refrigerator, it's gonna seem thicker. And I'll put that into a pan and I'll get my pan hot, and that oil will very quickly kind of thin out and spread across that pan as the pan heats up. That's kind of the way I think about synovial fluid. So it starts out really thick, but as you warm it up, it thins out, it gets less thick, gets more watery, and it does a better job of lubricating. Now we do say that because your body is making synovial fluid from your blood, it takes energy to do this. You're not going to make a ton of synovial fluid unless you need it. And so your body creates something called weeping lubrication. And that means that when you put the joint under pressure or you start using the joint, that's when you start creating that synovial fluid and it'll start to leak into that synovial cavity. But if you're not using your joint, body's not going to use the energy to make synovial fluid. So a great example is like when you're sleeping at night, right? You're not going to be pumping out a ton of synovial fluid into your knee joint. You don't need it. But in the morning when you wake up and you stand up, well, you're going to start weeping that synovial fluid in. I notice, you know, as I get older, I notice that like my joints are way more stiff in the morning. And so it just takes me a minute to get moving. And that's just that synovial fluid's weeping out. It's got to warm up. So a lot of times, you know, we talk about how important it is to warm up before you exercise for your muscles, right? It's important for your muscles that they get warm. It's also important for your joints that they warm up. We also have an articular capsule. So remember, this is what's kind of holding the synovial fluid in that synovial cavity. So we say it encloses the cavity. There's actually two parts to the articular capsule. I'm going to show you a picture. There's an outside part called fibrous capsule, and then there's an inside part called the synovial membrane. So in this image, I'm going to use the picture over here on the left. We can see around the outside, this part right here, that's that fibrous capsule. It's in gray, right? And the fibrous capsule is made of fibrous tissue. It is super tough. So it's really helping to not only hold the fluid in that synovial cavity, but it's also really helping to kind of strengthen the joint a bit. And then we also have this, there's our fibrous capsule. We also have a synovial membrane, which is the one that's in green. Okay, that's on the inside. And that one's a lot thinner. And the synovial membrane is there really to reduce friction so that you don't generate too much heat in your joint. Okay, and those two things together make up the articular capsule. So in the image over here on the right, you can kind of see that articular capsule here, right? And you can see really well that space, that synovial cavity. You're actually looking at the image on the right. This is the shoulder joint. So you're actually looking at right here is the glenoid cavity, and then this is the head of the humerus. Now, the last thing I'll mention are the reinforcing ligaments. These do exactly what they sound like they do. They help to reinforce the joint. They make it stronger. We have two different kinds of reinforcing ligaments. We have what are called capsular ligaments. These are actually thickened parts of the fibrous capsule. So your book doesn't show this. There's nowhere where we can see capsular ligaments, but it would be like this gray fibrous capsule here just gets thicker. Okay, so we would call that a capsular ligament if it were inside the fibrous capsule. Okay, now I already mentioned that the fibrous capsule does a great job of helping to support the joint and reinforce it and make it stronger because it is a really tough tissue. So those are capsular ligaments in the fibrous capsule. And then we also have intracapsular and extracapsular ligaments, right? And these terms kind of give it away. Intra means within, extra means outside. So these are ligaments that are either inside the capsule or outside the capsule. Okay, so in this image, we only see some extracapsular ligaments, right? So like this one here, that's a reinforcing ligament, but it's outside the fibrous capsule, right? It's on the outside. An intracapsular ligament, this image does not show one, but a great example would be like in your knee joint. In your knee joint, you have some ligaments that are in here. Those are intracapsular ligaments. You might have already heard of these, maybe your ACL, anterior cruciate, or your PCL, posterior cruciate. A lot of times if you play sports or if you know anyone that's played sports, sometimes you can tear your ACL or your PCL. Those would be intracapsular. They're inside that synovial capsule, okay? So those are just some of the common things that we find in our synovial joints, right? So you should be able to identify those in the picture, kind of know what they do. Now I also have a couple of other structures that I want to walk you through. Not every single synovial joint has these, but they are common in a lot of our synovial joints. So sometimes we might have something called a fatty pad in a synovial joint. It is exactly what it sounds like it is. It is a pad of fat. And if you think about the function of fat, it is there to cushion and insulate and absorb shock. And that's exactly what a fatty pad does. It is just there to cushion. And a lot of times we find a fatty pad like in the knee joint, and I'll show you pictures of this as we go through the knee joint. You can also find fatty pads in your hip joints as well. Discs or menisci, these are fibrocartilage pads. So remember, fibrocartilage is a type of cartilage that's super tough, can withstand a lot of pressure. So you'll have a pad of fibrocartilage actually separating the two articulating bones. So where the two bones come together, they're actually resting on a pad of cartilage. This is going to do a lot of things. One thing that this disc or menisci can do is it can actually improve the fit between the two bones. They fit together better because they're sitting on like a little cushion. Another thing that it can do is it can stabilize the joint and it minimizes wear between the bones. So obviously you've probably heard of the meniscus of the knee, okay? The meniscus, and I'll show you pictures in a minute. The meniscus is between the femur and the tibia. There is a pad of cartilage between those two bones. Really helps to improve the fit. Now, I don't want you in your mind, it's easy to think, oh, it's like a little soft, squishy pad. It is not soft and squishy. Menisci and cartilage in general is tough. I mean, you know, if you've ever eaten a chicken wing and sometimes you can actually find that pad of cartilage in there. It is not soft and squishy. I mean, it's a little bendable, but it is tough. And so the meniscus of the knee is really, really tough, but it's also really slick. So it's there to really help reduce the friction, absorb some shock. It's not uncommon as you age for the meniscus to get worn down. If your meniscus, if that cartilage gets worn down, your two bones start rubbing on each other, and that becomes super painful. A lot of times people might have to have knee replacements when this happens. Sometimes people can actually tear that cartilage. They can tear the meniscus, but because the meniscus isn't squishy, it's really hard. If it tears, it kind of bubbles up. And now when you bend the joint, you have this big bubbled section rubbing on the bone and it hurts. And so that's when they might go in laparoscopically and actually shave it down a little. They'll shave the cartilage down. But if we think about one of the functions of the meniscus, it helps to improve the fit. So if you shave the cartilage down, the fit's not going to be the same. So the joint becomes less stable, right? So you'll have discs or menisci between the knee. Obviously, we've been talking about the knee, but also you have it in the jaw and even in the shoulder, you'll have this as well. Some other things that you might find that help to reduce friction. Ooh, let me see if I can never have examples. Other things that will reduce friction are things like bursa. I was looking to see, my son leaves his, I call them his little droppings. He leaves toys and things all over the place, but I don't have anything in here. I was looking for a little ball because bursa are like little balls. I think of them as like ball bearings. So they are little fibrous sacs that are filled with synovial fluid. And you're going to have them where you have a lot of structures coming together. You'll have them where you have like ligaments and skin and tendons and bones and all these things. When you're moving the joint, they're all kind of rubbing together. And if you put a little, think of like a marble or a ball. If you were to rub your hands together like this, you generate friction, right? And your hands start to get hot from the friction. If that's happening in a joint, that's painful. So if you were to take a marble and put it between your hands, I'll just use my pen, and now you rub them together, not generating any friction, right? And so that's the whole point of bursa. They're like little ball bearings that really help to cut down on the friction within your joints, okay? Tendon sheath are pretty similar. Tendon sheath are like bursa that sort of are flattened out and wrap all the way around a tendon. So I'll show you some pictures here. This image right here, you're looking at a shoulder joint. And what I just circled up here is a bursa. It's like a little ball, a little marble, filled with that yellow synovial fluid. And every time that joint moves, that little ball just kind of moves and rolls around. So it's really helping to reduce friction. You can see it over here on the right as well. You can see that bursa. And they're trying to show you in this image at the bottom, they're trying to show you the bursa rolling around. Now a tendon sheath is very similar. You can see one here. It's a bursa that kind of, you can see they flattened it out and it wraps all the way around a tendon. You can see it's sort of wrapped all the way around. Doing the same thing, it's reducing friction. But now in this case, a tendon sheath will reduce friction all along the length of that tendon. Now, you might be familiar with bursa and tendon sheaths because you may have heard of something called bursitis. Bursitis, remember, itis is inflammation of the bursa. Well, if that little marble gets swollen, it's not reducing friction, it's now generating friction. So usually you'll have a lot of pain when you start moving that joint. You may have also heard of something called tendinitis. Tendinitis is inflammation of the tendon sheath. Again, it's not going to be able to reduce friction if it's swollen. And in both of those cases, they're treated with anti-inflammatories, right? Something like Aleve, something that'll just take the swelling down, and usually the pain will go away. So those are all some of the structures that we find in our synovial joints. All of those structures are there to serve a purpose, whether it is reinforcing the joint, making it stronger, whether it is preventing wear and tear on the joint, whatever it is, they all serve a purpose. Now remember, I know I've mentioned this, your joints are the weakest part of your skeleton. And so we have to stabilize our joints. We have to make them strong so that they don't dislocate or that you don't have joint problems. And so the things that will determine how stable your joints are, there are three things that will determine the stability of a joint. Okay, so the first one is the shape of the articular surfaces. So what that means is how the two bones fit together, the articulating bones. Now notice I have right here in parentheses, minor role. Well, this is important, but it's not the most important of these three. So how well those two bones fit together. If you have a shallow socket, this is something we talked about in chapter 7. A shallow socket, remember, would be like when the acetabulum in the hip, instead of being this nice ball and socket joint, if the acetabulum is shallow like this, then the head of the femur can slide out, right? That causes dislocation. And so a misfit, anytime the two bones don't fit together, anytime you have a shallow socket, the stability of that joint is decreased. The second thing that plays a huge role in the stability of a joint is ligaments, the number and the location of your ligaments. Now again, this says it plays a limited role. It is not the most important. So remember, we have these reinforcing ligaments that make your joint stronger. Joints are the weakest part of our skeleton, so we have to make them stronger. And honestly, these ligaments are going to help to not only reinforce the joint, but they're also going to prevent undesirable motion. And so your knee joint, for example, I'm going to show you an image of your knee joint in a little bit. And the knee, honestly, it's got ligaments that run up and down, right and left, diagonally. They're running all different directions. And there's so many ligaments on the back of your knee that you can't even see the bone. And so that's telling you right there that all those ligaments on the back of the knee, they're preventing undesired motion. They're stabilizing your knee, and they're preventing your knee from hyperextending, right? Bending the wrong way. Now, sometimes you might fall, or you might have some kind of traumatic accident. Usually it's with sports injuries where your joint will bend the wrong way. And if that happens, your ligaments will stretch. But remember, ligaments, they're not stretchy. They're really tough. They're made of that dense, regular connective tissue. That is not a very stretchy tissue. It is a very tough tissue. So your ligaments can't stretch much, only about 6% before they tear. If a ligament tears, because it's that dense, regular connective tissue with all those collagen fibers running in the same direction, when it tears, it honestly looks like the ends of your hair, right? So you have all these fibers sticking out. Surgeons equate trying to sew two ends of a ligament together, a broken ligament. They say it's like trying to sew two bristle hairbrushes together because you've got to try to get all those fibers together. So it's super tough. Now, usually what we say with ligaments is that if you partially tear a ligament, if you just tear it, part of the way through, it'll heal on its own. It's going to take a long time because you don't have a great blood supply to your ligaments, to that tissue, but it'll heal on its own. If it's completely torn, it requires surgery. They'll either have to try to sew it back together, or they'll have to do a ligament graft and pull a ligament from somewhere else. Now, the last thing that will stabilize a synovial joint, and this one is the most important, so I'm going to star it because people don't realize this one. Muscle tone. So having tone, tight muscles, it means that if your muscles are tight, then the tendon that passes across that joint is going to be tight. And if the tendon is tight, now you have more stability in the joint, right? So keeping your muscles nice and toned and taut keeps the tendons taut and keeps the joint more reinforced and more stable. This one is incredibly important, especially in joints like the shoulder joint and the knee joint and in the arches of the foot. Super important. In fact, when I was in college, when I was in undergrad, I went to Ohio State University for undergrad. I was on the crew team, so I was a rower. And before that, when I was in high school, I used to swim. I was on the swim team, taught swim lessons, and I was a swim coach. But rowing uses very different muscles than swimming. And so going through conditioning and training, I was using different muscles and muscle groups than I was used to. And at Ohio State, the campus is huge and you can't drive. There's too many, there's like 60,000 students. So nobody has a car. And so you walk everywhere. And I would have to walk all the way across campus and I would have to hobble to my classes because I was having so much knee pain. And I ended up going to the team physical therapist, and they did some images and they said, nothing's torn, but they said, we think what's happening is you are working the muscles on one side of your knee joint really, really hard, but you're not working the ones on the other side of the joint as hard. And so what's happening is the muscles on one side are nice and tight and the tendon's pulling really hard, and on the other side it's loose. So your joint's a little off kilter. So they gave me some exercises to do to strengthen the muscles on the other side of the joint. It took 2 weeks for that pain to go away after I started doing those exercises. It didn't take long at all. A lot of people have back pain. And one of the reasons why back pain is so prevalent is that if you think about it, we use our backs all the time. So our back muscles are so strong and tight, and all those tendons and ligaments are tight. But what we forget to do is work out our stomach and our abdominal muscles. And those are on opposite sides of the joint. And so what happens is the joint becomes unstable because you're pulling on one side and not the other. So if you have back pain, one thing you can do is lose weight, but then also start exercising your core. Get your core stronger, and that'll help. So people forget how important muscle tone is to your joints. Making sure, this is why when people work out, we always say, work opposing muscle groups. If you work your bicep, You also work your tricep. They're opposing muscles, right? One will cause you to flex at your elbow. The other one causes you to extend at the elbow. They span that joint on different sides. So it is really important that you work both of those, okay? So muscle tone is super important in joint stability. So I'm going to walk you through a little bit, now that we know about synovial joints and what they look like in their parts and pieces, let's walk through the movement of synovial joints. One thing that we'll talk more about, especially as we get into chapter 10, are these terms right here, the origin and the insertion. Now, I mentioned a little bit about this, but whenever you have a muscle in your body, a skeletal muscle, your skeletal muscle is always going to span a joint. Like if you think about, your bicep, for example, right? The bicep is going to span across your elbow joint so that when the bicep contracts, you are going to flex at the elbow, right? If your bicep doesn't span the elbow joint, if it just runs from like the top of the humerus to the bottom of the humerus and it's not spanning a joint, if that muscle contracted, you'd get no movement. So it has to span a joint to get movement. So what we say is that your muscles, your skeletal muscles, always attach at two places. One place is called the origin. The origin is the bone that's not moving when the muscle contracts. Okay, so that's the immovable bone. The insertion is where the muscle connects to the movable bone. Okay, so let's go back to our bicep example. The bicep runs from the coracoid process, which remember that's up in the shoulder, all the way down to the radius and the ulna. And when your bicep contracts, you get this kind of movement, right? You get flexion at the elbow. So what we would say is that where the bicep connects up here at the coracoid process, that's the origin. That's not moving when the bicep contracts. And where the bicep connects down at the radius and the ulna, that's the insertion, because that is what moves when the bicep contracts. We also say that the insertion always moves towards the origin when the muscle contracts. So the insertion is moving towards the origin. Another example that I can give you of this, like I said, we'll talk more about this in chapter 10, but another example is the muscle right here. This neck muscle is called the sternocleidomastoid muscle. I know, that's a mouthful. But this muscle is actually named for the origin and the insertion. So it connects at the sternum and the clavicle. So sternocleido. And then it comes up here and connects at the mastoid process. So this is why we call that muscle the sternocleidomastoid muscle. And this muscle allows you to turn your head side to side, right? So the origin of the muscle is the sternum and the clavicle. That's not moving when that muscle contracts. The insertion is the mastoid process. That's what's moving, right? And when that muscle contracts, the insertion gets closer to the origin. All right, so those are just two examples. Again, we'll talk way more about origin and insertion in the next chapter. So I do want to walk you through a little bit on our synovial joints and the types of motion that we can get out of our synovial joints. The very generic ranges of motion are non-axial movements. Non-axial movements are where the bones just sort of slip and glide over each other. Axial movements are where you're moving the joint on a plane. So uniaxial, uni means one. So this would be movement in one plane. So good examples like your elbow, right? At your elbow joint, you can hinge in one plane, right? I can't move my elbow side to side. That doesn't work. It only goes in that one direction. Another example would be these last two synovial joints here. We call these our interphalangeal joints. So these last two, not this one here, not this one, but these last two, right? They can only move in that one plane. I can't move them side to side. That's uniaxial. Now biaxial, bi means two. So this would be when you can take a synovial joint and you can move it in two planes. So a good example of that is going to be this joint here in my finger. This is called the metacarpophalangeal joint, right? Because it's between the metacarpals and the phalanges. And this joint, I can move in that direction or in that direction. So that one's biaxial. And then multiaxial, multi means many. You can move it in many planes. And so great examples are any ball and socket joint. It's like your shoulder joint and your hip joint, okay? So those are some very generic ranges of motion, types of movement that we can get. And then we also have these different types of movement, some general movement types. And all of these are going to fall into one of the categories I have listed here on the previous slide. Okay, so gliding movements. Gliding movements are when the bones sort of glide over each other, sort of a slipping motion. So great examples are between all these carpal bones in here in your wrist. When you move your wrist around, these carpal bones kind of slide over each other. Again, let's go back. Those are all non-axial movements, okay? Angular movements, these are moving along a plane. So some angular movements that are a little more specific that we might find might be some uniaxial movements like flexion, right? Extension, hyperextension. Other movements are things like abduction, adduction, and circumduction. I'm going to go over all of those with you. I'm going to show you pictures of all of those, okay? But those are all types of angular or axial movements, like uniaxial or biaxial. And then we also have some rotational movements. So turning a bone around its long axis, like this, right? That would be a rotational movement. Or even being able to rotate your forearm, right? That's a rotational movement. So let's go through some of these more specific movements of synovial joints, right? So the first one I told you is gliding movements. So, you know, when you wave your hand this way, you've got some gliding happening here within those carpal bones. Some angular movements would be things like flexion or extension. I always remember that flexion decreases the angle, and extension increases the angle. Sorry, I don't know what it's doing. So again, if you think of like your bicep, well, this one's easier. So if we think of the finger, right, these last two joints here, I can flex them. Okay, so in anatomical position, I have just taken this angle and made it smaller. I've decreased that angle. Or I can extend. An extension increases the angle. Okay. And then we also have hyperextension. Now, I cannot hyperextend these joints. That would mean going beyond anatomical position. They would go backwards. I can't do that. But there are some joints you can hyperextend, right? Like here, I can flex my neck, I can extend it, and then I can hyperextend it, okay? She's showing you in this image the shoulder joint. You can flex your shoulder joint, you can extend it, and then you can hyperextend it, go beyond anatomical position. Okay, it's the same thing. So you can see the neck, and you can see you can do it at the trunk too, right? You can hinge at your trunk, flex, extend, and hyperextend. Another set of angular motions would be abduction, adduction, and circumduction. So abduction is moving away from the midline. So abduction would be like if you're standing in anatomical position and you move your arms out to the side. That's abduction. You can do the same thing with your legs, right? You can move your legs to the side. Abduction. What is that? Like cheerleaders do it and they put their legs out to the side? I can't remember what that's called. I don't know. I was about to say a word that, I don't know. That wasn't it. Adduction is bringing them back to the midline. So adduction is coming back to the midline. So I always remember adduction because it has add at the beginning. You're adding it back to the middle. Okay, so you're bringing it back to anatomical position. And then circumduction is movement like a cone in space. So I think I don't have a picture of that. Oh, there is an image right here on the side. I can't see it. Mine's covered up. Circumduction would be like if you take your arm and kind of move it like a cone in space, right? That is circumduction. Okay, I'm not rotating my arm this way. I'm creating sort of a cone. Rotational movements, that's our last one. These are turning the bone around a long axis. So again, you can rotate your head and then you can also rotate your arms, right? This is rotation, not circumduction. You can do the same thing with your feet and your legs. You can rotate those as well. All right, so those are all some very general types of movements that we find within our synovial joints, okay? And I'm sure you've heard of that before, like flexing and extending. Now, I also have a list of some special movements. Now, these are some movements that are very specific to specific joints. Okay, so we're going to walk through these. You have a list of them here. I'm just going to show you some pictures. So the first one, this is called supination or pronation. So supination and pronation, these are specific to your palm. When your palm is up, it's supination. And I just remember because it has up in the name, supination, palm up. If you rotate and put your palm down, that's pronation. The reason this is a specific movement is this only can happen here with this particular joint, with the wrist joint, and it is happening between the radius and the ulna. If you supinate when the palm is up, the radius and the ulna will be parallel with each other. But when you pronate and put your palm down, you can see in this image, the radius and the ulna actually cross each other. You can feel this on yourself. If you supinate and kind of hold your radius and your ulna, so palm is up, hold your radius and your ulna, and then you try to pronate and put your palm down, you can actually feel the radius and the ulna just cross over each other. Okay, so that's a very specialized motion. Another specialized motion is in the feet, dorsiflexion and plantar flexion. This is basically flexing the toes and pointing the toes. This one, when I was learning this, I thought this one was really hard because I remember taking ballet as a kid. And if you ever, go to a workout class, they talk about flex your toes and point your toes. We don't say dorsiflexion, plantar flexion, and these both have flexion in the name, so that makes it even harder. So how I remember this one is dorsiflexion is flexion, right? Flex the toe, pull them up. Plantar flexion is point, and I remember because it starts with a P, right? So point. So plantar flexion is point, dorsiflexion is flex. Okay, those are specific just to the feet. We also have inversion and eversion, again, specific to the feet. This is at the ankle joint. You can invert your foot, meaning turning the sole or the bottom of your foot inward towards the medial side, or you can evert your foot, meaning you can turn it more lateral. Okay, so in this image, this would be the midline. Okay. Protraction and retraction. These are special movements that we can find in some synovial joints. Protraction means to push it forward. Retraction is to pull it backward. So this example is showing you at the mandible, so you can protract and retract the mandible, push it forward and bring it back. A lot of times when I'll ask students, hey, give me another example, A lot of times they'll tell me the tongue. And tongue is a muscle, right? It's not a joint. So we're talking about bone joints here. So something else that you can bring forward and backward would be like the shoulders, right? You can pull your shoulders forward, pull them backward. Okay, so protraction, retraction. Elevation and depression. Elevation is to lift it, depression is to push it down. Again, we can do an example with the mandible. We can also do an example with the shoulders, right? My son is really good at this one. Right? Raise the shoulders, lower them. Elevate, depress. Opposition is a special movement only found between the thumb and all the other fingers. So your ability to touch your thumb to all of your other fingers is called opposition. And this has to do with the joint that we find in our thumb, the type of joint called a saddle joint, which we'll talk about in a little bit. Okay. So those are all some very special motions that we find within our synovial joints. We have a lot of different kinds of motions in our joints. I'm going to walk you through, this will be the last thing we talk about. I'm going to walk you through our 6 types of synovial joints based on the shape of the articulating bones and the kind of movement that we have. So we're going to basically take all of what we learned about our synovial joints, different kinds of motion, how the articulating bones fit together, and now talk about here are our 6 major types of synovial joints that we find in the body. Okay. You have them all listed here. I'm going to go over them with you and show you pictures. So the first one is a plane joint. This is where the 2 articulating bone ends are essentially flat, right? So you can see the articulating surfaces are very flat. And it really only allows for those non-axial gliding motions. And so a great example here is going to be those carpals, right? It's where the 2 ends are flat. They only provide those non-axial motions. A hinge joint is exactly what it sounds like it is. Think of the hinges on your door. They allow for you to open the door and close the door. I cannot lift the door up, right? So like the door of my car, I can open it, I can close it. I don't have a Tesla. The door doesn't hinge up this way. It's only in one direction, okay? And so how those articulating bone ends look is very similar to a door hinge. You're going to have one bone with sort of a cylindrical projection on it, and that's going to fit into like a trough on the other articulating bone. Looks very much like a door hinge. And a great example is here. You can see, remember, we have our humerus. Remember, here's the trochlea. And then we have our ulna, which remember has that trochlear notch. This is a fabulous hinge joint. And it only allows motion in one plane. Remember, it is a uniaxial joint. So examples of hinge joints, obviously the elbow joint's a great one. Another one are the interphalangeal joints. Remember, inter means between the phalanges. So these last 2 knuckles here, right, those are hinge joints. You only get motion in that one plane. A pivot joint. A pivot joint is where you have one articulating bone that's really round, and it's sitting kind of in the sleeve or a ring that's sometimes made of bone, sometimes it's made of ligaments. It just depends. So you can see just sort of the artist rendering here, where you can see that you might have a bone that has sort of this rounded projection, and it's sitting in sort of a sleeve of the articulating bone. So a great example of this one, the one that they give you, is the radius and the ulna, right? So remember, the radius is not really making up much of your elbow joint. It makes up more of the wrist joint. So up here where your elbow is, you can see the radius, the head of the radius looks like the head of a nail, and it sits within sort of a sleeve of ligaments from the ulna. Remember, we have that radial notch right here that the radius can sit in. And so it allows the radius to rotate. Another great example is between C1 and C2. Remember, atlas and axis. So remember, C2 has that thing that sticks up called the dens, and C1 kind of sits on top of it and can rotate around the dens. Okay, so those are some examples. Again, this is just a uniaxial movement, so just movement in that one plane. We also have something called a condylar joint. And this is where you might have one articulating bone is sort of an oval shape, and the other one, so it's sort of convex, and the other one is concave. They fit together. This is not nearly as big of a groove as a ball and socket joint. So condylar joints are just a little more shallow than that. They do permit all angular motions. So they do allow for biaxial movement. And a great example is this metacarpophalangeal joint right here, right? So you can move it in two different planes, biaxial movement. Okay, so they're giving you that example right here. A saddle joint is where you have, I mean, to me, it looks like the two articulating bones, the ends of them both look like saddles, right? So it sort of looks like a little saddle that you'd put on your horse, okay? And they fit into each other. They're really similar to condyloid joints. They're just deeper and they allow for a greater range of motion. And the only example that we have of this is right here with the thumb. So this is what is allowing your thumb to have this huge, great range of motion. Okay, and this is how it allows us to touch all of our other joints, that opposition. And then the last one, a ball and socket, looks like a ball in a socket, right? And this one allows for the most freely moving of all of our synovial joints, so it allows that multi-axial movement. The examples of this are going to be your shoulder and your hip. Those are both ball and socket joints. All right. So we have gone through how we classify our joints. Let me pull up a whiteboard up here. All right, so remember, we have gone through how we classify our joints functionally. And so remember our functional classifications. We have synarthroses. We have amphiarthroses. And we have diarthroses. Okay, so these are immovable, slightly movable, freely movable. And then we also walked through the structural classification of our joints. And we talked about how we have, well, we started with fibrous joints. Fibrous joints, right? And remember our types of fibrous joints. So remember we have sutures, we have syndesmoses, and we have gomphoses. We talked about cartilaginous joints. And for cartilaginous joints, we have synchondroses and symphyses. And then lastly, we talked about synovial joints. And that is what we spent a lot of our time talking about. We talked about with our synovial joints, we talked about the structures in a synovial joint. So reinforcing structures, all the things that we find in those joints. And then we spent a lot of time talking about movement of our synovial joints. Okay, so we've hit on a ton of new terms today. What we will do on Wednesday is we will finish out this lecture, chapter 8, and we will talk about specific synovial joints. So the rest of this chapter, we left off down here, we will go over the jaw, we will talk about the shoulder, we'll talk about the knee and the hip. So we're going to do some of the big joints that people usually have issues with. And then we'll do some imbalances. We'll talk about things like arthritis and stuff.